So, hello and welcome everyone to episode 14 of CCLG's Research Talks, Parents and Public. So I'm Ellie Ellicott and my job is to share research with our supporters. So let's start with some housekeeping. So we'll be holding a Q&A session at the end of the talk. So please do submit your questions when you think of any using the Q&A button that should be at the bottom of your screen. If you'd like to use the chat function, please do make sure you set the to drop down to everyone or people might not see your message. So the webinar is being recorded and will be available publicly on our YouTube channel. And we'll send the link out when it's ready to watch, which might be later this week or early next week. So this month's talk is called How Do We Get the Right Doses of Cancer Treatment and is being led by Dr. Shelby Barnett. Shelby is a lecturer at Newcastle University and one of the leads for the Pharmacology Research Group. Her focus is on medicines for children, particularly chemotherapies for very young babies. She worked on a Little Princess Trust funded research project that has helped find the best doses for over 300 young patients and published extensive dosing guidelines for doctors to follow. So without further ado, I'm going to hand over to Shelby. Thank you.
Brilliant. Thank you, Ellie. And thank you everyone for giving me the opportunity to present here today and share my research with you. It's a lovely summer's evening, so thank you for taking the time to watch this talk. I'm Shelby Barnett, as Ellie said. So I'm a lecturer of cancer pharmacology at Newcastle University. So my perspective of childhood cancer is purely kind of from a lab side rather than so much dealing with cancer in the clinic. So today we're going to look at getting the right dose of anti-cancer drugs in childhood cancer patients. And I'm part of a team here in Newcastle University, so the Newcastle Cancer Centre Pharmacology Group. And we look at clinical trials in cancer. So we're split into kind of three groups here. So we have Julie and Lulu on the clinical trial management side of things, and we have Alistair and David looking at the pharmacodynamic biomarkers, and then myself and Gareth looking at the pharmacokinetics. And between us, we've got 3 PhD students and 2 postdocs working on various clinical trials. So what is pharmacology? Well, it's the study of how drugs affect a biological system. And when we talk about clinical pharmacology, we're really looking at it in humans rather than animals. It's usually split into 2 categories. So we have pharmacokinetics, which describes what the body does to the drug in terms of how it's removed and distributed around the body. And then we have pharmacodynamics, which describes what the drug actually does to the body, so how it exhibits its effect. So, as I said, we're interested in pharmacokinetics of drugs. So when you give a drug, so that could be oral or IV or injection, it needs to get into the body and it follows a set of processes that we call ADME. So this is absorption, distribution, metabolism, and excretion. So when the drug is administered, it's absorbed into the blood. And when it's in the blood, it can travel around the body so that it can get to where it needs to go. So in the case of cancer, this may be tumor cells where it can exhibit its effect. So when it's distributing around the body, it's also passing through organs such as the liver. So it can then undergo metabolism in the liver and then be excreted out through the kidneys in the urine or in the bile in the feces. So that's how we get rid of drugs from the body after they've been administered. But how do we kind of measure these processes? Well, to do this, we need to take blood samples from the patient after they've had the drug. So as you can see here, this is what we call a concentration time profile. And this is achieved by taking blood samples from the patient just after the drug has been administered and for various time points after it. We measure the drug in the blood. So you can see here, this is a drug that has been given orally. Over time, it will gradually increase in the patient's blood as it's being absorbed until it reaches kind of its maximum concentrations. And then after it's no longer being absorbed, these concentrations will fall in the patient's blood over time. And that's because it's being eliminated and removed from the blood. So this profile is what we tend to look at a lot in pharmacokinetics. It's how we estimate some parameters that we're interested in, such as clearance, so how quickly it's being removed. But also it allows us to get an idea of the exposure of the drug within the patient. So we do this by calculating the area under the curve. So the area under this kind of profile that we see here allows us to determine how much of the drug the patient has been exposed to over time. If this profile were higher, sorry, I'll pop my pointer on. If it were higher, we would this would be a higher exposure of the drug, and if the profile were lower like this, it would be a lower exposure of the drug. And it's really important that we understand these parameters because it helps us decide on the dose of the drug. So it was this happy chappy here, Paracelsus, that said, poison isn't everything and no thing is without poison. The dosage makes it either a poison or a remedy. And that's true for pretty much everything. Everything has its limit that you can take within the body, even water. Too much of it can be poisonous to cells. So our group work on various kind of aspects of clinical trials and do clinical pharmacology studies. So the three areas that we look at are early phase clinical trial work. So this would be phase 1 studies of investigational drugs that companies are hoping to get onto the market. So we work really closely with Cancer Research UK in order to look at the pharmacokinetics of these drugs. We also do therapeutic drug monitoring, which is a study which I lead on, which looks at individualizing dosing in challenging patient populations. And then we also do clinical trials on drugs that are on the market and well established, but we're looking at kind of modifying the dosing and best combinations of these drugs. So how do we get a drug onto the market? It needs to go through a clinical trial, and there are 4 phases to a clinical trial. So we have phase 1, which is in about 15 to 50 patients, small number of patients. And this phase is kind of the first in human, and we're really focused on assessing the safety of the drug. So this isn't looking at how effective it is within a given population. It's just looking at how safe is the dose that we're given, and can we find the most tolerated dose. If a drug passes this phase, it can go on to phase 2, where we start looking at the effectiveness of the drug and we increase the patients that we're looking at this in. We might have a better idea of the dosing in these patients, and we will be looking at kind of side effects. And if a drug passes phase 2, it will move on to phase 3. So this is when we have a good idea of the effectiveness of the drug, and we're comparing it to kind of treatment options that are already available. And again, the number of patients that are on a phase 3 clinical trial increases. So we have kind of hundreds of patients rather than tens of patients. And then if this treatment is shown to be effective and the drug is released onto the market, then we have kind of a 4th phase. So this is when the drug is being given to large amounts of people, so thousands of people, and we're monitoring kind of long-term effects and toxicities for this drug. So this can go on for many, many years. And how do we work out the dose that we are giving these patients? So this would typically be done in phase 1, and this is a typical approach of how we would do this. There are some slight variations, but just to kind of illustrate how this can be done, we would start with a low dose in patients based on kind of preclinical and animal work. This level of drug would be given to 3 patients. If these patients had no kind of dose-limiting toxicities, so any horrible toxicities that would stop them from taking the drug, we would then increase the dose and test this in a further 3 patients. Again, if this was well tolerated, we can increase the dose to a further 3 patients. However, if a patient had a dose-limiting toxicity, we would then look to expand this kind of dose level and test this in a further 3 patients. Providing that these 3 patients tolerated this dose level well, we could go up to the next dose level. However, as you can see here in this example, 2 of these patients have had dose-limiting toxicities that have kind of stopped the use of the drug, and that means that this is kind of the maximum tolerated dose of the drug. So what we would do here is drop the dose back down to the previous dose level, and that would be the dose that we would take forward into a phase 2 clinical trial. And through all of this, we're looking at establishing kind of therapeutic windows and making sure that we're dosing drugs appropriately so that we're not seeing excessive kind of toxicity. So the therapeutic window is the range of exposure that provides sufficient therapeutic response, but without significant toxicities. So this is just kind of illustrated here, where we have kind of as the exposure of the drug increases, we see increased efficacy or response. However, we will also see increases in toxicity, and we want to find a nice happy place where we're seeing the best amount of efficacy for the drug, but limiting that toxicity, because at a point, the efficacy of the drug will kind of plateau and we won't see anything apart from kind of excessive toxicity. So how do we dose anti-cancer drugs in children, though? Because it's quite a challenging situation. And many of the drugs that are used in children with cancer are kind of older, established cytotoxic agents. And most of the pharmacokinetic data and dosing data comes from adults. So the use is generally unlicensed and off-label. And what we do is we scale the dose from adults based on body weight or body surface area. And for kind of very young patients or patients with kind of kidney or liver impairment, we might see additional dose reductions that can be kind of quite arbitrary. So, for example, if a patient is less than 6 months of age, they may have an additional kind of 50% dose reduction. But children are not just small adults. And if we think about kind of 15 to 20-year period of an adult's life, there's not much that really changes in terms of organ development and kind of size of the patient. However, the first 15, 20 years of childhood, there are dramatic changes. And, you know, we have infant cancer patients that are being dosed within the first kind of days and weeks of life, and they're going to handle drugs differently to kind of an infant or a toddler or a young child kind of age 5 compared to teens and young adults. So we can't just necessarily scale the doses just by size. We have to investigate if there's anything else that could be affecting the pharmacokinetics of the drug. And this is particularly evident in infant cancer patients. So there are many developmental changes that occur within the first few weeks, months, years of life that can affect how a drug is handled within the body. So we have changes in the kind of drug metabolizing enzymes that break down medicines. This just illustrates kind of the various enzymes that we see and the expression of them and how they change over the first kind of few years of life. We have changes in total body fat and body water, which can affect how drugs are distributed into different tissues and how they get to their target site. And we also have changes in kind of kidney function, renal function, and that will affect how drugs are eliminated. So what we tend to see is these kind of arbitrary kind of dose reductions in children that account for these potential changes. Clinical pharmacology studies are not routinely conducted in children. But we really want to address the question is, what is the rationale for these dose adjustments? Is it because there's truly differences in drug disposition in these kind of infant patients, which affects how they're eliminated from the body? and that's why we need dose reductions? Or is it because infant patients are more susceptible to kind of drug toxicity, and that's why we need to kind of change these doses? And if we look at childhood cancer, as I said, many of these drugs that are used are older, more established cytotoxic agent that have kind of quite horrible toxicities. They've been around since the 60s and 70s. We actually do see quite good survival rates for childhood cancer these days. If you look at this, so this is an example for acute lymphoblastic leukemia. So kind of from when survival records were recorded from the 60s, you can see that there would be about a 30% 5-year survival rate in the 60s. However, now this is from the early 2000s, and up to now it's like 85%. And actually the drugs that we've been using during that time haven't really changed. We don't see a lot of new drugs coming through in childhood cancer. Sometimes we see some drugs that are developed from an adult population kind of trickling down into pediatrics, but generally it's kind of the use of established cytotoxic agents, Vincristine, doxorubicin, cyclophosphamide, for example. But it's actually over this time we've become better at understanding what combinations of chemotherapy are good in childhood cancer and kind of the dose intensity, so how much of the drug to give and how often, and that is what's led to the improved survival rate. However, you know, we still can investigate these further. As I mentioned, kind of for infant patients, there's still a lot of work that needs to be done. So we can investigate these dosing in kind of hard to treat patient populations like infants to improve outcomes. So how do we improve this dosing? I'm going to talk about kind of 3 areas for the rest of my talk. The first, looking at, can we improve the way we administer some drugs to patients? Secondly, can we individualize dosing in some patient groups? And 3, can we generate evidence-based dosing guidelines from data that we've generated in children? As I mentioned, the kind of clinical pharmacology studies and clinical trials aren't routinely done in children. The drugs that we use were initially developed in adults, so that's where a lot of the data comes from. Can we generate data based in children for children? So let's look at designing more appropriate formulations for children. So most drugs are not designed for children. This is an example of 13-cis-retinoic acid, which is used in kind of the maintenance treatment for neuroblastoma. So for this drug, it's given in capsule form, so it's like a gelatin capsule with a liquid inside, twice daily in 2 weekly cycles, 2 weeks on, 2 weeks off for 6 months. Now, in neuroblastoma, we do see many patients kind of at quite a young age, below kind of 3 years old. So the trouble with this kind of capsule form is many of these patients kind of refuse or are unable to actually swallow these capsules. And at the time that we looked at this drug, there was no kind of liquid formulation available. So to get the drug into these patients, you would have to kind of cut the capsule and squeeze the liquid out from it, usually into yogurt or something to kind of disguise the taste. But obviously cutting a capsule and squeezing the drug out, it's not the most effective way to dose patients. And what we found was that for these patients who had this kind of extracted drug, so squeezed out and into food, they had lower exposures compared to children who just swallowed the capsule whole. And that's not good because that means they're kind of getting subpar dosing compared to patients who are taking all of the capsule. So this is what prompted kind of the reformulation of the drug that can be used in an infant population. So we were involved in a study kind of looking at the pharmacokinetics of this new formulation. So it was put to a panel of children, and Tutti Frutti flavor was the favorite. So that's what we went ahead with in a kind of liquid formulation. This was a crossover study. So patients either had this liquid formulation or they had the reference compound, which is the capsule cut and squeezed into some food like yogurt. And we monitored the levels of the 13-cis-retinoic acid in these patients. I must also mention that one of the problems with cutting the capsule is obviously 13-cis-retinoic acid is a teratogenic compound, so it can cause birth defects. Now, this isn't necessarily an issue for the children who are taking it. However, as this is being taken at home for 6 months, you may have mothers of these children dealing with this drug and cutting them open, and we really don't want them to be exposed to this kind of compound that can cause birth defects, because they could be pregnant or planning to have kind of further children. So it was really important that we design this this formulation. So as I said, kind of a crossover study, they had either the capsule squeezed into yogurt or this liquid formulation. We monitored the levels of the drug in the patient, and then 2 weeks off, and then they switched. So whatever they didn't have before, they would have. So, but each patient had both the new test compound, which is the liquid formulation, and the capsules that are extracted. And what we found from this study is that we designed a well-tolerated formulation, so parents found it easier to use. We didn't see any kind of increased toxicity, and the children approved of the taste of the liquid formulation. And in terms of, did it increase kind of the exposure of this drug in patients? Well, yes, it did. You can see here this blue line here is the exposures of the liquid formulation in patients compared to the red line, which is the capsule. So it did help fight against that kind of discrepancy that we were seeing in patients who were needing to have the drug extracted. So now this liquid formulation is available and it's on the market, so it can be used in this kind of patient population. So next I want to talk about therapeutic drug monitoring and how we can use this to individualize dosing. So therapeutic drug monitoring is kind of utilizing that therapeutic window that we talked about. So for any given dose of drug within a kind of population, most patients will fall within the therapeutic window and have very good exposure that's well tolerated. However, for some patients, we will see kind of reduced exposure of the drug, which can lead to decreased efficacy or response. And we may also see kind of very high levels of the drug, which can lead to toxicity. And this is all to do with kind of variability just within patients. Remember, they've all received the same dose of the drug. However, they just may handle them a little bit differently. And it's really hard to know what exposure a patient has. The only way that you can do this is to measure the levels of the drug in patients' blood samples. So how we do this is how I mentioned before. So the drug is taken, and at defined time points after the drug has been taken, we take some blood samples so that we can measure the drug in the patient. We then use these levels that we've measured to see where the patient falls. Do they have too high exposure? Do they have too low? And then we can adjust the dose accordingly so that they can fall within the therapeutic window. But unfortunately, we can't do this for all patients, all pediatric patients, and we really focus on patients who we expect to have differences in kind of pharmacokinetics, or reasons why we would really need to monitor them. So for example, high-dose chemotherapy patients, they're going to be dosed near the kind of maximum tolerated dose, and edging on that kind of creeping over into kind of excessive toxicity. But for other patients, so for infants and neonates, as I mentioned, there are changes in development that could affect how quickly they're removed from the body. Patients who have kind of poor kidney function or liver function, that can affect how drugs are metabolized and removed. Again, obese and malnourished patients, how these drugs are distributed. And then finally, we look at a kind of a group of patients that are receiving kind of standard chemotherapy, and we wouldn't expect them to have kind of marked differences in how they metabolize or eliminate drugs. But for whatever reason, these patients don't tolerate the chemotherapy very well, and they have very excessive toxicity. And when that happens, they receive kind of marked dose reductions. So, for example, 50% dose reduction. For these patients, we want to make sure they're still obtaining efficacious levels of the drug. So we also monitor the levels in these patients. So we run a study within the UK that looks at therapeutic drug monitoring in these challenging patients. It was initially funded by the NHIR Research for Patient Benefit Award, and then the Little Princess Trust, and now the ECMC. So it's been running since 2019. We currently have 16 centres open for recruitment, highlighted by these purple stars here, in the UK that are recruiting patients onto the study. We've had just over 330 patients recruited so far since 2019, out of our kind of target of 750. As you can see, majority of these patients fall within the infant and neonate category, and this is largely due to concerns over dosing with dose reductions. Clinicians come to us identifying a patient that could benefit from having their levels monitored. But we also see kind of good recruitment from other groups as well, so renal impairment, high-dose chemotherapy, and toxicity. So we have assays available to measure kind of 12 of the most commonly used anti-cancer drugs in childhood cancer. So the most popular ones that we monitor are Vincristine, etoposide, and Carboplatin. But as I said, we have assays available to measure 12 of these drugs. And how patients get recruited onto a study is we're not really looking for these patients. The patients are coming to us through kind of a clinician identifying them because they feel that this would be the best treatment for their patient and to have that kind of dosing support. So if we agree that it could be beneficial for their patient, we would design a sampling sheet so that we could sample the patient for all the drugs that the clinician would like to monitor. And then when the team have this kind of sampling sheet, they can take the samples, ship these samples to us overnight, where they're received in Newcastle, and we can monitor them in one of two ways. So we have kind of two types of analysis. One is atomic absorption spectroscopy, which is looking at metals. So we use this to monitor the drugs carboplatin and cisplatin. However, most of our assays are for measuring are using liquid chromatography and mass spectrometry. So this is quite a sensitive method for measuring kind of very low levels of drug that we would see in patient blood. This is what we use for majority of our assays. This can take quite a while to extract the drug from patient samples, and usually these samples kind of run overnight. So this isn't something that we can do for the patients within kind of real time within their current within the cycle of chemotherapy. For example, if they're getting the drug for 4 days, we can't do this with LCMS. It would have to be a dose adjustment for the next cycle of chemotherapy. So when we have the levels of drug, the data from the experiments. We verify this, and then we compare it to kind of clinical pharmacology studies that we have been doing in-house for many years. So we have a good idea of what a normal range of exposure should look like in a pediatric population. And we also have literature data from, scientific journals, other studies that people have published. So we can see where that patient would fall within the normal range, and then we can report the results to the clinician. And of course, if the levels are looking out of the norm, so either too high or too low, and the clinician decides to make a dose adjustment, we can monitor the levels on the next cycle of chemotherapy just to make sure that that was an appropriate dose adjustment. So just to illustrate how this can be of benefit, so this is an example of a 15-year-old patient with Ewing sarcoma, so not a patient we would initially kind of flag that would benefit from therapeutic drug monitoring. However, during the treatment on vincristine, ifosfamide, and actomycin D, they were having some quite severe platelet recovery. So the chemotherapy kept being delayed due to this delayed platelet recovery. So they were recruited kind of due to toxicity. The team treating them had tried multiple dose reductions over several cycles of chemotherapy, but with no real kind of evidence or to support these kind of dose reductions. They were just trying to see which combinations worked. So when we did therapeutic drug monitoring on this patient, you can see here, these are the levels of each of the drugs for the patient. The blue dashed line is kind of the normal range that we would expect to see. So for vincristine, the patient had the full dose, so they had no dose reduction for this. And you can see here the levels are falling kind of within the normal range that we would expect. But for actomycin D, you can see that they had a 66% dose reduction, so they were receiving 33% of the dose. And you can see here that with this dose reduction, they're actually quite towards the lower end of the normal range that we would expect to see. So we advise not dose reducing this drug any further. However, for ifosfamide, they received a 33% dose reduction, and you can see they're at the top of this normal range that we would expect to see. Now, you can imagine that had this patient had the full dose, and which they did on previous cycles, they would be well over this kind of normal range. So we suggested that if any dose was to be reduced on the next cycle, we would go for ifosfamide. So that's what they did. They reduced the ifosfamide dose by 50%, and you can see here the levels fell more within the normal range, within the middle of it, and this actually led to improved platelet recovery. So this is just to illustrate how a therapeutic drug monitoring can benefit individual patients and how it can support clinicians making dosing decisions. But I also want to show you what we do with this data kind of on the whole. Obviously, we use the TDM study to help individual patients, but then we also collect that information for all of the drugs to see if we can improve dosing guidelines for these drugs in future patients. So I'm going to give two examples of this for vincristine and carboplatin. So vincristine is used in a variety of protocols for various tumor types. We were getting to a point on our TDM study where we had quite a lot of infant and neonate patients receiving vincristine. So we wanted to see if there were any differences in the pharmacokinetics in these infants, so less than 2 years of age, compared to kind of a standard pediatric population between 2 and 18 years of age. And what we noted from the data that we collected was that the dosing in these patients less than 1 year of age or 12 kilograms, their dosing was quite variable. So they were either dosed according to body weight, so between 0.02 and 0.05 mg per kg, or between 0.75 and 1.5 mg per meter squared. So the dosing there was quite variable compared to older children who received kind of a standard dose of 1.5 mg per meter squared, capped at a total dose of 2. And what we were interested in with both sets of these patients is two pharmacokinetic values. So that is exposure, or the AUC, so the area under this curve, how much they're exposed to, and the clearance of the drug, so how fast vincristine is getting out of these patients. And what we found was there was no significant difference in how quickly these drugs were removed from neonates and infants and these older children. However, there was a difference in the exposure of these two groups of patients. So neonates and infants had significantly kind of lower exposures than these older children. Now, what this tells us, because there's no differences in how quickly this drug is being removed, it suggests that there's something going on with the dosing within these two patient populations. So we looked at this a little bit further. We split our infants and neonates into kind of two groups, those that receive doses less than 0.05 mg per kg and those who are 0.05 mg per kg or above. And what we found was these lower dose patients had significantly lower exposures than those dosed at 0.05 mg per kg or standard kind of older children who were dosed at 1.5 mg per meter squared, whereas there was no differences in exposure for the patients dosed at this level compared to older children. And interestingly, these patients who received the lower dose of vincristine, they weren't necessarily the youngest patients. So this just kind of illustrates the variability in kind of dosing protocols that, you know, in some dosing protocols for various tumor types, you may actually have patients receiving, older patients receiving lower doses, if that makes sense. For these patients who had lower exposures, we suggested dose increases, and they were well tolerated in these patients. So that suggests that we shouldn't be initiating vincristine treatment at dose levels below 0.05 mg per kg. And also for these patients here, so they had quite high exposures for vincristine. And this was due to, we didn't recommend kind of the doses to be this high for these patients, but the clinician was really pushing the treatment because of the aggressive form of cancer that they had. They really wanted to get the most out of their treatment. However, they did experience excessive toxicity at this level. So this helped us identify a potential therapeutic window for vincristine of between 50 and 100. So we now actually use this window going forward for patients to suggest that patients fall within this window. Another example of where the TDM study has been beneficial is generating a lot of evidence-based dosing for carboplatin. So carboplatin is mainly eliminated renally by the kidneys, and as I mentioned, that change in kidney function changes quite dramatically over the first few weeks and months of life. For carboplatin, we have a really good understanding of the link between the exposure of the drug and the efficacy that we see, but also the toxicity. So at high levels of carboplatin, we see increased incidences of toxicities such as ototoxicity, so kind of deafness. And obviously we want to prevent exposures that could increase the incidence of ototoxicity, because we don't want to be exposing these kids to levels that could so that they could have kind of lifelong impairments. So for carboplatin, we typically target an AUC, so an exposure of 5.2 in patients. And the CCLG actually have kind of treatment recommendations that suggest that you do therapeutic drug monitoring for carboplatin for several tumor types in patients who are less than 3 months of age. So that's actually standard of care for patients who are receiving carboplatin less than 3 months of age. So when they're targeting an AUC, an exposure of 5.2, if they're less than 5 kilograms, they receive a lower dose of 4.4 milligrams per kilogram per day. However, if they're between 5 and 10 kilograms, it's a little bit higher at 6.6 mg per kilogram per day. It's important to note the patients that I'm talking about here all received therapeutic drug monitoring, so they all achieved their target exposure of 5.2, but we just wanted to look at what would have happened if they hadn't had therapeutic drug monitoring and their levels adjusted. What do the current dosing guidelines illustrate for this drug? So we had 82 patients below 10 kilograms. And again, similar to Vincristine, the pharmacokinetic values that we're concerned about is the exposure and also the clearance of this drug. And similar to Vincristine, what we found was there was no significant differences in clearance or the dose required to achieve a target of 5.2 in these two groups of patients. So since there's no differences in the clearance, this suggests that we don't need to have that kind of dose reduction of 4.4 mg per kg for these patients less than 5 kilograms, because it's not supported by the evidence that we have here. We also showed a good linear relationship between body weight and clearance in these patients. So that allows us to estimate the most appropriate daily dose for these patients, and that is 1.15 milligram per kilogram per day required for every AUC of 1 targeted. So when we look at this to target an AUC of 5.2, and I'm using 5.2 as an example here because we can, for different tumor types, they may target different values, but generally for infants, we target 5.2 in the first instance, and if it's well tolerated, we can increase. So the dose needed to achieve a target of 5.2 from our evidence suggests a dose of 6 milligram per kilogram per day. And what this looks like compared to current dosing guidelines is, so here we have our 2 patient groups again, so those less than 5 kilograms and those 5 to 10 kilograms. We're looking at the percent of the target AUC that they would have achieved. So this blue line is within 10% and the yellow line is within kind of 20%. You can see for the patients who are less than 5 kilograms, who would have had the lower dose, a lot of these patients are outside of those kind of acceptable limits of achieving their target AUC. However, by increasing the dose to 6 mg per kg per day, we have more of these patients within that kind of target window that we would hope. Equally, we're proposing kind of a slight dose reduction for those patients who are 5 to 10 kilograms, as the kind of exposures were slightly higher on the whole within this kind of therapeutic window. And by reducing this level, we reduce the variability between patients, so the spread, and also get more of these patients within that therapeutic window. So we would still recommend that patients receiving carboplatin, these young patients, that they we use therapeutic drug monitoring to guide their dosing. However, this information is really important because this kind of service of measuring these compounds is quite unique to the UK, and not everybody has access to be able to monitor these agents. So this information is really useful for other countries who don't have access to these methods. They can dose their patients more appropriately. And just to really touch on that a little bit more, this therapeutic drug monitoring study that we have is really unique to the UK. So it's the only program of work that really monitors such a large number of chemotherapeutics in pediatric in real time to benefit their treatment. We're becoming kind of quite recognized for this internationally, and we do see an increasing number of clinical requests coming from Europe for us to monitor patients, challenging patients that clinicians may have. Since the study has been so popular, we're focusing on expanding the kind of number of analytical assays that we have. to measure these drugs so that we can measure additional agents. So we are currently in the process of developing assays for fludarabine and thiotepa. And this also allows us to expand into other kind of disease specialties that may use the same agents, so we can use what we've learned in a cancer setting to benefit more patients. And because of kind of the innovation and novel and uniqueness of this study, it actually we were awarded the Innovation and Practice Team Award from the CCLG 2 years ago. So that was very kind of very lovely kind of a recognition of the work that we do from our peers, so the research nurses and the clinicians, and to kind of recognize the kind of importance of that work. So just to summarize, as I've shown, kind of dosing drugs in children can be challenging, as most of the data comes from adults. But we can use clinical pharmacology studies to optimize this dosing so that we can improve the treatment in these patients. Our TDM study, so our therapeutic drug monitoring study, has been really well received by both clinical teams and parents. People are really keen to have those results so that they can make informed dose decisions when treating their patients. And collecting this data has allowed us to kind of benefit the individual patient, but also improve dosing regimens for future patients. And our future work will focus on making this standard of care for these drugs that we've shown evidence for where TDM is really beneficial, expanding our candidates for therapeutic drug monitoring, so the drugs that we can monitor, and maybe looking at some kind of ways that we can increase the expansion of this study. So for example, using kind of microsampling devices so that patients can take blood samples at home and reduce kind of visits to the clinic. So these are all things that we're looking at to kind of make therapeutic drug monitoring kind of more widely available to patients. So thank you for your time. I would like to thank just everyone who's been involved in these clinical pharmacology studies and the TDM program, everyone that we work with, importantly, the research nurses who collect the samples. So this photo here is from our kind of research nurse training day that we had earlier in the year, where we all get together and discuss kind of the best ways to take samples and sample documentation and kind of share experiences. And then finally, just to thank all of the patients and families involved in our studies, because their data is really meaningful and it's going on to help future patients as well. And I'm happy to take any questions that you may have.
So, well, firstly, thank you. I mean, would you mind screen sharing if that's okay with you?
Sorry, stopping the screen sharing.
Yes, if that's okay.
Yes.
Then everyone see our lovely faces. I mean, I always say wow at the end of these talks, but I think, like, you know, developing new drugs obviously so important, but learning to use the ones that we do have could make such a big impact right now. So yeah, amazing. So I think everyone else thinks so too. I'm just going to talk for everyone else here. But we do have some questions, if that's okay with you.
Yes, of course.
So Kill had a question a bit earlier on about slide 13. So I probably shouldn't have asked you to stop sharing the screen.
That's okay.
And I regret that now. I'm sorry.
I can share the screen. Let's
Sorry.
let's go back. So slide 13. This one here. Oh, sorry.
Yeah. So he said it mentions hard to treat populations re childhood acute lymphoblastic leukemia. Could you please elaborate / define?
Yes, so hard to treat patient populations. So the context that I'm meaning this in is kind of those patients that I talked about a little bit later, that we monitor on our therapeutic drug monitoring study. So they're kind of the non-standard pediatric populations that would require dose adjustments and aren't receiving kind of standard chemotherapy. So these hard to treat patients are the infants and neonates, patients with hepatic and renal impairment, obese or malnourished patients, kind of high dose chemotherapy patients, so patients who aren't receiving kind of standard treatment, and they have kind of dose adjustments. It's really investigating what those dose adjustments are based on, what's the scientific rationale for those, and that's how we can improve kind of the dosing in those hard to treat patients.
Thank you. I think that is all of the slide related questions.
Okay, yeah,
I'm gonna say that now, and I am so sorry if another slide related question comes that is gonna make me ask you to slow down again. But whilst we're on ALL, so a question from someone on the Q&A module. It's not making sense to my brain, so I'm going to read it to you. It's probably me being dumb because it's a very warm day.
Yeah.
So it says, high-dose chemotherapy patients that are being used in studies, would this be, for example, ALL patients on regimen C, or would an ALL regimen A patient be classified as high-dose chemotherapy?
So, apologies, I'm not on the clinical side, so I don't deal with kind of those kind of standard dosing regimens. I don't know what that means. Apologies. I don't know if there's kind of a hematologist out there that would know what that kind of dosing protocol is. When patients come to us, they tend to give me the kind of dosing in actual numbers rather than kind of what arm they're on. So apologies for that. I'm sorry. I will take this this question from the chat, and I will look it up for you.
Okay, I can send it to you afterwards. I'll make me note to send you that. Okay, let's move on to a therapeutic drug monitoring question. So that is all you. So can therapeutic drug monitoring feasibly become a standard routine clinical tool for use with all child patients, and what are the barriers?
Okay, so that's a really good question. So in other areas, therapeutic drug monitoring is actually quite commonly used. So for other drug classes, so antibiotics, immunosuppressants, for example, anti-HIV drugs, it's not kind of routinely used in cancer. One of the kind of barriers to it, I guess, is kind of maybe patient numbers, especially kind of looking from a childhood kind of cancer side of things. The patient numbers are quite low. You need people who have kind of expertise in this area to kind of set these assays up and know what these kind of values mean. Also, you to understand if you can use therapeutic drug monitoring to benefit patients, you have to have a good idea of what the kind of normal exposures are, and if there's a link between the exposure of the drug and the efficacy and toxicity. So if you don't have that information available, you could develop an assay to measure a drug in a patient, but it wouldn't have any meaning if you don't know what you're targeting, if that makes sense. So I think the idea, especially in kind of childhood cancer setting, is for the drugs where we're starting to gain evidence that it's beneficial, to make that kind of more widely spread. There are various companies that are looking at kind of developing point of care devices to measure these drugs in patients in the hospital. In this setting, at the moment, samples are sent to us, so obviously that's quite that reduces the amount of patients that we can actually monitor, because we're just one lab doing it for the whole of the UK. So I do think it still has a bit of a way to go, but we're definitely on the right track to making it standard of care for patients.
So you mentioned earlier about being able to possibly in the future use smaller, like at-home things. Is that sort of like finger prick tests, and would that mean that it wouldn't need to be wet samples, that it could be perhaps like dry blood spot type?
Yes. So that would be appropriate for drugs that are kind of given orally daily at home. So some of these kind of tyrosine kinase inhibitors like imatinib, where we'd be looking at there's good evidence to support kind of the trough level, so the kind of early kind of morning level of the drug before you take your kind of next dose, and what that level is. You want it over like a certain level. So for drugs like that you're taking at home routinely, yes, to have microsampling, so dry blood spots, where you can just note down when you took the sample from a finger prick and send it to the lab, and it can kind of be reported that way. So that is something that we've been looking at.
Wow, that would be like so like efficient and useful for families once they get over the stabbing their fingers, but I'm sure they've been through worse by that point. So so speaking of trough levels, Mohammed would like to know, do you think trough level or TDM through the cycle would make a change in the outcome of diseases like Ewing sarcoma or sarcoma in general?
So does that mean within the treatment cycle, or
think so.
kind of between the treatment cycles?
It says during the cycle.
During the cycle. So yes, so for example, in Ewing sarcoma, there are kind of multiple days of ifosfamide and kind of etoposide. So if you were looking to dose adjust, kind of you get your samples from day 1 and you could adjust on kind of day 3, 4, and 5. Potentially that could be beneficial. We just kind of need the evidence for those drugs that it would be beneficial. I did say that we don't tend to do dose adjustments within the cycle for drugs. We actually do for carboplatin, so that kind of other method for measuring drugs. It is really beneficial there. So for carboplatin, that's given over 3 days. We take sample on day 1, analyze it on day 2, and adjust the dose for day 3. And that is really beneficial within the patient's treatment cycle. So it just has, I guess it's a combination of factors, showing that we can appropriately dose adjust to a good level for those drugs within the cycle, because for some of the drugs at the moment, we don't necessarily have a target that we're trying to get the drug to. We just want to minimize the variability that we're seeing within patients. So some patients might have a very, very high exposure. You can see that right away, and we can drop the dose. Equally, if it's very low, we just want to make that variability a lot smaller, rather than going to a defined target. So we would need a defined target, but certainly, we are looking at drugs like fludarabine, where that's given over 4 days, and we would look to dose adjust within those 4 days for that drug. So it's a challenge, and it's a bit of a push because it's tight timelines, but it definitely can be achievable for some drugs that have that evidence. So yes, so it's something that we do plan to do.
It sounds like you've got a lot planned.
Busy.
Well, I think we have reached the end of the questions, and we should probably let everyone go digest all of the things they have learnt. So I will say my little thing, if that's okay with you.
Yes, of course.
So firstly, thank you very much to you for your fantastic talk and all of the answers. I think we've all learned a lot. It's very interesting. Thank you. And thank you to everyone else for joining us this evening and for your questions. So this talk has been recorded, and we will be sending it out to you in the next few days if you'd like to share it or watch it again. You'll also be receiving an email shortly asking for feedback on today's talk. This is so that we can make sure our talks are the very best they can be. So please do take a couple of minutes to let us know what you thought. And have a lovely evening, everyone. Thank you.